Good morning again, everyone, and welcome back to the Fertility Forum 2021 and to the second panel of the day. Just a couple of things. If you weren't in the first session, the entire event is being recorded and we'll be sharing it widely after the event. So if you miss one of the sessions, please feel free to kind of sign in afterwards and view the panels which are of particular interest to you. If you're in the audience, then we have a Q&A function. Please feel free to fire some questions at our panelists during the panel session, and I'll do my best to pass those questions on to our panel here. So in our first session, we were looking at how COVID-19 had impacted this sector. We're going to look a bit further forward now and look at what the future holds for fertility treatment and the many IVF clinics that are attending both from the UK and internationally to this session. We have four excellent contributors to this panel: Helen, Alison, Salome and Cesar. I'm going to let them introduce themselves. I've asked them to do three things. Firstly, to share with us what changed for them during the pandemic. Secondly, just some brief background on who they are and the business that they're involved in. And thirdly, kind of speak about what they think is the most significant future trend that's going to impact fertility treatment going forward. So Helen O'Neill from Fertility Health, we're going to turn to you first, Helen. So over to you.
Hi there, can you see me? Can you see me? Can you hear me?
We can hear you loud and clear.
Great.
And
okay,
we can see you.
Okay, great. Sorry, I can't see anything other than the screen. Firstly, thank you for having me on this amazing panel. It's such a great lineup. I think definitely the thing that changed for me during the pandemic was that I had a baby and I started a business. So I was trying to run a business with a new baby from a very small apartment. So I think there was, if there was a skill that I took up, it was juggling for sure.
Are you still on?
I'm still here.
Yep. So give us a bit of background about yourself and what you see as the most significant future trend.
Sure. My background is in molecular genetics. I have a master's in prenatal genetics and fetal medicine and a PhD in stem cell genetics with particular focus on sex determination and the genes that are involved in ovarian development. I then became a tenured lecturer at UCL, where I directed a master's program in reproductive science and women's health and lectured about molecular genetics and the genetics associated with fertility and infertility. I have my own research group at UCL, and I, as I mentioned, started my own company called Fertility Health, which is a machine learning driven approach to understanding fertility and a symptom-based approach to diagnosing reproductive conditions associated with infertility in an at-home test.
And what do you see as the most significant trend for the future of fertility treatment?
I think for me, it's personalization. So personalized medicine is, we will no longer accept or rely on just generalized approaches to treatment and to treatment cycles. I think, to me, we'll have to look at the individual nature of both somebody's cycles and their symptoms, but equally their genetics.
Right. Thank you, Helen. Let's move to Alison. Again, those three topics: what changed for you, who you are, where you're from, and the most significant trend. Alison.
Hi. So what changed for me? Well, not a lot changed professionally for me because the fertility sector really had quite a short close down period. We were one of the first to reopen, and I was involved with writing the guidelines for the resumption of services for the fertility sector. So I was quite busy during that time. Personally, I'd say I spent a lot of time in my greenhouse. And I'm most proud, I'll share with you what I've been growing, loofahs plants. So these are subtropical vines, and the fruits, they're like sponges. So when you harvest them, you let them dry out, then you chop them, shake all the seeds out, peel them, and they're sponges for the bathroom. So yeah, I'm quite proud of that. Wouldn't have had the opportunity otherwise, so that was good.
So we had dahlias in the first session.
Oh,
so
really?
this is, yeah. Ying Jeong grew her first dahlias from seeds. So
Nice.
gardening was clearly a big thing.
Yeah. So yeah, introducing myself, I'm Dr. Alison Campbell. I'm Care Fertility's Group Director of Embryology. So I have a PhD in embryo selection. I'm a fellow of the Royal College of Pathologists, and I head up a network of 14 IVF laboratories across the UK and Ireland. So we work in a very cohesive way. So mostly I'm responsible for best practice, high standards, all the results, the pregnancy rates, and the research and the innovation across the whole group. Keeps me out of mischief.
It's your future trend.
So the future trend I just mentioned, I think, is egg freezing. So for women particularly, the chance of conceiving naturally falls as she gets older, and this is because egg quality declines. And preserving eggs when a woman is young, there's a nice slide there, it can be undertaken in case they're needed in the future. So egg freezing may resolve some of the pressure which surrounds important life decisions for women, like career, education, or even finding the right partner. So you can see on the slide here that these are Care Fertility data. So we have actually seen over the last 5 years or so an increase in egg freezing, a quite substantial cumulative annualized growth rate of 42%. And we know from the data that's provided by the HFEA, which is the UK regulator, there is also a national increase in egg freezing. And the reason for this, I think, is that awareness of fertility generally and availability of egg freezing has improved, which is great. And people are having a family later in life. And importantly, the technologies that we use in our laboratories has improved significantly. So we freeze eggs much more successfully than we ever have before. And the most recent advancement associated with egg freezing is the introduction of artificial intelligence, which is very exciting and making a really positive difference. So every egg that we freeze now in our clinics, in Care Fertility anyway, we use artificial intelligence to assess the quality of them. So this gives women much more information about the potential of those eggs to fertilize in the future, should they need to use them, and importantly, whether they'll be able to make a baby or not.
Thanks, Alison. Let's move on to our next panelists. Salome, welcome from Spain. Over to you, Salome.
Can you hear me?
You are loud and clear.
Okay, super. Hi, how are you? First of all, thanks so much for inviting me, for inviting us. If I had to say something about what changed to me or to us, to the group during the pandemic, it was that we had to close all our clinics in a moment that we had 3 new clinics to be concrete. So we have to reorganize ourselves to develop a new quality control system. And it was a little bit of headache, but as we were closed for a few months, we could manage it. So that was the most significant. And regarding me, I have been working in fertility over the last 14 years. Before I was working in financial companies, mainly in banking. I didn't have a medical background. I studied international trade, and then I did my PhD. I have had many responsibilities, different ones in this company, and nowadays I am the Director of Operations in Corporate Development. We are a Spanish group, We have 13 clinics all over Spain and 3 clinics in Central America. And well, that would be a summary of what we do, and about the trend that we think would be the trend for the next years. We think it's quite important to plead to obtain the healthiest embryo as possible. We think patients, they don't want just to be pregnant, but also to have a healthy baby. So to invest and to take care of developing new diagnosis systems to help patients to have a healthy baby, mainly.
Thank you, Salome. And move to our last panelist, Dr. Cesar Diaz Garcia from IVI in London. Cesar.
Hi, how are you doing? My name is Cesar Diaz, and when it comes to the things that really changed for me during the pandemic, I would say that the most important one was traveling. I used to travel a lot, both for personal reasons, my family is still in Spain, and for work. And honestly, I think that for all of us, traveling, even for patients, have changed dramatically during the pandemic. Thank God things are coming back to normal. I specialize in reproductive medicine in 2005, and I moved to Sweden after my OBGYN training to do a PhD in reproductive surgery, specifically in uterus transplantation. I feel very proud of that part of my professional career because I was part of the first team achieving live birth after allogenic uterus transplantation back in 2014. It was a very long process. Afterwards, I relocated in Spain, where I was leading the National Fertility Preservation Program. It was a centralized program for fertility preservation due to medical reasons, in which we achieved to treat more than 2,000 patients in a period of barely 6 years. And in 2017, I moved to IVI London, where I act as a medical director, and I still keep running a research line in Spain in our research institute, basically on fertility preservation and low ovarian reserve. When it comes to the questions related about trends in fertility, I would say that for the next year, probably what is going to make a difference is the development of less invasive methods when it comes to monitoring of patients undergoing ovarian stimulation, home tests for hormone measurements, and even ultrasound scans. And also when it comes to treatment, probably the big difference, we are going to see them in very poor prognosis patients, such as those with premature ovarian insufficiency, in which the projects on follicular activation, dormant follicles, and primordial follicles will probably open the door to new options for this group of patients.
Thank you, Cesar. Right, let's move to the panel session. And I've got some questions here, and I've got some that are coming in from the audience. So if we can open up the panel session for all 4 contributors. Okay, there's an anonymous attendee who'd like to fire this question at you, and I'd like a response from each of you. We'll start with Helen and keep this in the same order. What will be the shape of COVID recovery? This kind of follows on from our first session. Were 2020 and 21, was that a kind of temporary surge of demand, or is it going to result in a structurally higher level of demand over a multi-year period? So where's it going in terms of demand for fertility treatment? How might that change over the next few years, both from a UK perspective and from an international perspective? Helen, do you want to have a go at that one first?
I will. So to begin with, I think it was kind of a two-pronged approach to the demand. The first came from the fact that for once, people were working from home. They were able to actually take time to think about maybe what they might do in terms of their fertility and the fertility future. The kind of natural pace of life is that even when we're actually very sick, we don't take time to go to appointments because it's inconvenient, and it's something that actually doesn't make you ill, which is physically feel ill, is infertility is an ongoing for many who prefer to delay. So in ways it forced people to reconcile with their condition, with their desires, whether it was fertility or infertility. And it also increased people's acceptance with at-home testing. For us, it was very beneficial because at-home testing became the norm. People weren't, people became, au fait with giving a blood sample from home. It wasn't this kind of foreign entity. But now it's almost moved beyond that, it being novel to being almost demanded. People don't want to have to go to appointments all the time. They don't want to have to travel. They want things to be more digital, and they want things to be more accessible to them at home. So I think moving forward, it has changed the landscape in terms of both telemedicine, realizing you don't need to be in front of a doctor necessarily to speak to them. And in fact, there's a lot of comfort to be taken in being at home in your comfort zone when you hear results. So I think there's a real dynamic change that has come from this in a very good way.
Alison, would you agree with that? Hold a similar view or different?
Yeah, similar view. Yeah, great answer. Really, really comprehensive answer. Yeah, definitely much more virtual appointments we're seeing. And in terms of demand, yeah, acceptability seems to be up, and accessibility, at least through the private sector, seems to be up. I'm not sure what will happen with the NHS and funded cycles. We've got huge variability across the UK, and that's a challenge, I think. And some NHS fertility clinics still not open after the COVID shutdown. So some of those patients will make their way to the private sector. Some will not be able to afford to do that for private funded treatment. I think we'll see more employer funded fertility treatments, more benefit schemes in the near future, I imagine. Yeah, so I think that's probably.
And to what extent have you gone digital? How has this kind of move? We're in a virtual conference here. What's your view on that? To what extent have you adopted that? Has it changed? Are patients happy with that, or is? Patients
seem to be very happy with it, and I think until they're pushed into it, they hadn't realised how much easier it is. Not sitting in the traffic, not struggling to park. So we are encouraging virtual appointments where we can, and we're offering face-to-face now if they want it. But I think we will see much more continued virtual appointments, and as long as that suits the patients, then it suits the clinic. It's more efficient. They get the same information, and people are getting used to it.
Have you had to train staff to kind of, in online communication, let's say? Is that a new skill that we have to develop as clinicians or care professionals?
Yeah, I think it's an important new skill, and some people adapt very easily and others don't. I find myself now in a face-to-face meeting and people say, "Oh, I haven't seen you for 2 years." I don't feel personally like I haven't seen people. So obviously for me, it's very different to other people. So we need to be mindful of that. But digitalization, it's a big thing, and we are in the middle of a very large digitalization project. Patient portal is established, so patient information just pushes into their portals. They can access what they need when they need it. It's much more convenient. So I think it's facilitated, it's catalyzed all of those things that were inevitable, but it's a positive thing in many ways.
Yeah. Salome, are you seeing a surge? Do you anticipate a surge in demand post-COVID in Spain?
What we have had is our patients that couldn't come for the last year because of the borders were closed and many people wasn't vaccinated, and also people was afraid of traveling abroad. So that regarding international patients, And so they have increased right now. All of them, they came together since the beginning of July. It's now a big number of patients that they feel safe because, well, they have been vaccinated and they think that they can travel. So it is true that they have increased. And regarding a Spanish patient, they were also worried about having a fertility treatment because they didn't know if being pregnant was a problem, if there were any problem between pregnancy and COVID. There was a lot of lack of information because we didn't know. Nobody knew how this was going to develop. So yes, the demand, I think it will become stable, but for the last 4 or 5 months, it has been quite high.
And Cesar, for IVI in London, are you looking for a lot of growth in the future? What's the shape of that demand going to be like?
Yeah, I think that indeed it's also part of the past. We experienced that increase almost from the very beginning of the pandemic. As you are aware, we were forced to close for barely a couple of months, and after that, I agree with Alison. There have been a swift of patients coming from the public sector, for good or for bad. I think that the way the NHS will cope with their IVF units will clearly determine also the amount of patients that will move from the public to the private sector. But that's not something that we expect. It's something that is already happening.
Yeah. There's a question here which I'm going to fire just to Alison and Cesar initially, which is specifically about male infertility and improvements in diagnosis. This is more of a kind of clinical question. Alison, where do you see that going?
Oh, well, hi, Sheena Lewis, a professor of andrology, so a big expert in the field. It's a really good question.
Should Sheena answer the question then?
I was going to say, I think she knows what's in store for the future.
She's welcome to put her hand up and join. So,
yeah.
Well, your view.
So my view, well, first of all, just to say that a third of our patients, approximately a third, have male factor infertility. So it is a big issue and often overlooked. So in terms of the future for the guys, I think semen assessment will improve, probably using automation and potentially artificial intelligence, so making it much more reproducible and accurate. And we would hope to see improved diagnostics for men. So Sheena's an expert in DNA fragmentation, so more testing of the sperm DNA, testing for oxidative stress, so just a different impacts that can affect fertility in the male. I'd like to see improved sperm selection techniques. There's quite a few new devices out and about at the moment. I think a lot of scientists have been busy during the lockdown doing the research and trying to improve technologies. So preparation of sperm is important, and we've been doing it the same way for 30 years approximately, maybe more. So improved preparation techniques so that we select the best sperm to inseminate in the fertility labs. Also, I think that's coming soon.
Cesar, your view on that?
I completely agree. When I discuss with my patients about the sperm issues, I always say using the morphology is like trying to judge someone just by looking at their faces. We will clearly need to move to more accurate and functional assessments rather than morphology. Also, when it comes to the treatment, we will need to be more active, and that goes through the pathway of selecting sperm. There are different techniques already in the market, and probably there will be more coming, microfluidics and other techniques as the use of artificial intelligence, as Alison mentioned. And I think that the industry will need to invest in support whatever they propose with clinical data, especially in terms of live birth rates, which I think as clinicians we all need.
I fill a gap in my knowledge, if you could. So are males generally becoming more infertile? Is that? fact?
That's a trend that, in fact,
That is a trend, isn't it?
speaking, has been described since years ago. Not only based on the morphology of the sperm, but also on the prevalence of diseases related to the testicle. Especially testicular cancer is probably the only cancer who has increased by more than 200 times the
Right.
incidence in the last 50 years. So probably the answer is clearly yes.
Okay. Helen, you keep nodding. Do you want to add to that?
Yeah, I think there's never enough emphasis on our environmental exposures and just the huge increase of endocrine disrupting chemicals in almost every part of our lives, from newborns drinking out of melting plastic bottles. The first experiments were done in animals to show that it caused infertility. That was when the first kind of papers came out many years ago around the profound effect of endocrine disrupting chemicals. And this is why we see on all of our plastic bottles that these are free of phthalates, but it took a very long time for bottles to be free, to be declared free of these chemical compounds. And we're even seeing precocious puberty in so many teenagers, and there's a direct link with the precocious puberty and the amount of these endocrine disrupting chemicals in their environment and in their bloodstream. So I think it's a massive issue that is not really acknowledged.
Okay, thanks. Salome, I'm going to move to you, but I'm going to move to another question, and it's another one from the audience. What's coming to this sector in the next few years? What's going to be different, not only in terms of treatments, but what's going to be different for patients? We've heard a couple of mentions, AI has been talked about, online virtual consultations. Are those the major changes that are going to impact the sector, are going to be different in the sector? Are there other things that we're missing?
I think we need to focus in we can do different approach. The first one would be, of course, online consultation and digitalization. It came to stay. Patients, they want to be more agile in the treatments. So we need to train ourselves. We need to be ready to have all our systems digitalized, to offer online consultations, to offer all the documents and informed consents to be signed online, so they don't need to approach our clinics. It is true that there are some phases of the treatment that I think that has to be, we need to have a touch, okay? You cannot do everything online, maybe the initial phases or the initial steps, but then when you need to talk to them about something seriously, or we need to give a diagnosis, it should be face to face. We don't think this should be online, because finally this is a medical field where human touch must be important, okay? As Helen was explaining before, personalized treatment should take the whole integral part of the treatment. And I think another, from the medical approach, genetics will play a significant role. As I tried to explain before, patients look for just to have a healthy pregnancy. So we won't have just patients with infertility or reproductive problems, but also patients who want a genetic healthy baby. Okay, that will be another, we consider a kind of patient that it will arise.
Okay, Cesar, same question. What's going to be different?
I think probably, I mean, the best way to summarize it is just to say that patients will have more. They will probably have it in a less invasive way. And again, as any business sector, probably they will have it, especially in the private sector, cheaper.
Okay. Chuck a question at you, Alison, and it's about, okay, we're going to see increased demand for a variety of factors. The issue of supply, and in supply, I'm talking about donor eggs, donor sperm, which is, a block on on growth and availability. How do you see the future of those aspects?
Well, the need for donor gametes, donor eggs and sperm isn't going to go away.
No.
And at least in the UK, we've got some situations where clinics are sustaining themselves. They recruit their own donors and have a nice steady supply for patients, and other examples where we rely on importing from overseas. So I think the availability is there, but it would be better if we could just recruit for ourselves, which we are endeavouring, at least at Care Fertility, to do that. So we don't have to rely on external banks. So then you've got full control over everything, the quality and the donors. And we've got quite strict regulations in the UK about the payments, compensation payments. So we need there's a lot of tight monitoring, as you can imagine, regarding donation. So I expect that, it will continue, it will increase, and clinics will find ways to be self-sustained in terms of supply and demand.
And that presumably, whether you were in the earlier session talking about potential investors, looking for IVF clinics or groups that were kind of self-sustaining, that had the infrastructure, for that kind of thing to make them more attractive to a purchaser.
Yeah, it makes sense. And I think when you're working as part of a group, you have the power to do that. And it's not optimal to recruit donors from one city, and we've got a family limit, but nevertheless, it's nicer to have a network and to share the donors across the nation rather than to keep them all in one smaller location. So yeah, it's important, and I'm sure investors are looking closely at that. And some groups have acquired donor banks, donor egg banks overseas. It seems to be cost effective to do it like that. Again, it's a challenge to keep keep the limits to the standards high. So I don't have any direct experience with that, but I know that happens. Unfortunately, we don't currently have a problem with supply where I'm working.
Okay, there's another kind of clinical type question. Maria Georgia from Greece is saying there's a lot of noise about the impact of mRNA vaccines and their impact on reducing fertility. Is there actually any data about this? And do you think this is going to affect success rates? Is there anything related to, to the vaccines that we should be concerned about, or you think there may be concerns about? Or is it a myth? Cesar.
I don't think it's a myth.
Helen first.
Sorry, I stepped in
far away.
It's not anecdotal, but from our data perspective, we definitely cannot ignore, though it's inconvenient to acknowledge, that there have been changes in people's cycles, changes in people's regularity. Given that we test people's reproductive hormones on day 3 of their cycle, we had an influx of people contacting us saying, well, I've actually been bleeding for 21 days. When do I test? Or I haven't had my period since I had it. We started to look into doing a study about this, and I felt like everything we did to try and put together information was almost like putting your neck on a block to say, I am at risk of being Andy Wakefield if I speak out on anything that is negative towards vaccines. And it was a very strange dynamic to be in, because you want to publish the data because it's scientific, but you don't want to go against, something.
The need for vaccines. Yeah.
Exactly. So I didn't, and then there's so many confounders. You have to start to look into people's change in their personal circumstances, in their working circumstances. Working at home during the pandemic has meant people have exercised less, they've eaten more. There's so many confounders that I felt in ways like we had our backs against the wall. But it's a difficult one. I don't know. I think given how many people have had a vaccine, it's strange that there hasn't been more research dedicated to finding out specifics.
Yeah, Cesar, your view.
I agree that the data we have so far is reassuring. But I mean, an outcome such as fertility, which sometimes requires years, I think it's maybe a little bit too early to say 100% that the COVID implications in fertility are inexistent, but I would say it would be fair to say that it looks like the impact, if any, probably would be minimal, both for the disease and the vaccines.
Okay. I'm coming back to this kind of the extent to which we've gone online in healthcare and in our life generally. And there's a couple of questions in here about really kind of going down the route of, okay, going online makes it easier for you, your clinics to kind of manage patients, but is this a good thing for patients? So someone's saying, okay, virtual consultations, fewer exams take place. In terms of men, they need more clinical exams. And it's actually kind of damaging communication. Are we going too far? Within the NHS, and the whole thing about GP consultations and the government telling GPs, you must see people face to face because we think it's better, and that's what patients want. Is there a downside to this move to virtual? Who'd like to go first? Dive in.
I think that oh, sorry.
There you go.
I think the virtual consultations have not come to be a substitute of the physical ones. So there is a lot of things that you can do during a virtual consultation, a lot of time that you can save, and then therefore you can minimize the time that you require to do other things. But that the virtual consultations obviously will never replace physical examinations, for example, in the case of male or female patients, or alternative tests that they are part of the assessment of the infertile couple. So those will need to take place anyways.
Salome, it must be an important part, with your international business, particularly the kind of move towards virtual.
We consider that online consultations are quite important, mainly for international patients. Now that we have learned to deal with them properly during the pandemic, we were doing already video conferences before, but now they are something that we do with every patient. But it's something that as I explained before, it's for an initial consultation or for pre-diagnosis or to talk about something and a specific thing. But we have taken from online consultations, I think clinics have taken the good and the bad. Okay, we had to take into considerations that patients need to visit the clinics, need to meet the people who is treating them, see the facilities, doing all the exams. There are all exams that can be done at home, but medical examination, as Cesar has explained it very well, is not a substitute of physical consultations, but it's a complement, okay, as something to make consultations more agile, or if you need a consultation in a specific moment, of course it can be done online, but they need to have a limit.
Okay, thanks. A question that I have, rather than from the audience. In the earlier session, our sponsor was talking about the kind of consolidation that's happening in the market. So, we're getting clinics being acquired, groups being acquired, bigger chains, bigger businesses, rather than the kind of historical one-off IVF clinic driven by clinicians. Is that good news or bad news? What are the kind of challenges and benefits of this? We're getting bigger. Are we getting better? Alison.
Yeah, I think it's good news. I can see that for a standalone fertility clinic, it could be daunting, the prospect of that. But I've got first-hand experience, and I'd say it's good for everybody concerned. It's good for the patients. It should, and it does improve success rates. The combined knowledge of multiple clinics, providing they work well together, means that you've got all those specialists that can support each other and give the best treatment for the patients. We collect data on a very large scale, and in that data, is information that we can use to make further improvements. We've got economies of scale, and there's flexibility with staff supporting each other across. If we're short-staffed in one laboratory or nursing department, we can share staff across the group. So I think, I personally think it's great news. Of course, there are challenges, and I think just looking at what's going on across the world, it seems that the biggest challenges will be where companies come together as a merger or an acquisition, where the cultures or the visions differ.
Yeah.
So that's really important. But other than that, I think with the right management team, it's fairly straightforward and successful.
I'm going to fire a question in from Jenny Jenkins. Says this whole issue about treatment add-ons, clinics offering the treatment add-ons, including kind of those with, say, limited evidence of being effective. How do you deal with that within IVI?
In fact, we based our practice in scientific evidence, in evidence-based medicine. So obviously, it's up to each clinic to regulate their own practice. But in a country like the UK, we also have the role of the HFEA, sure, which makes things much easier and also much more transparent for the patients. So in a context like the UK, I would say that the use of add-ons still exists. That's a reality. But I think the patients are more protected in a way that they have an external actor who they can rely on in order to seek information, objective information, and to contrast it with the information that is given by the clinics and by the clinicians. Okay.
Salome, in Spain, you don't have an HFEA, quite the same kind of level of regulation. Is it more a kind of open market if clinics want to provide add-ons, and is that seen as a patient benefit or as a kind of marketing advantage for the clinic?
Well, it depends on the clinic. We don't have, as you tell, the HFEA. We have a Spanish Fertility Society, yeah, that I think each clinic regulates itself. I think that you should take case by case and offer patients what you think it can improve the treatment. Of course, according to our model that we are hospital units, okay, all our clinics are inside of a hospital. We try to respect as much as possible the pureness of the treatment, and we just deal with some add-ons techniques, and others we tell them, listen, this is something empirical. If you want, you can have it, because it's true that there are patients coming and demanding these add-ons. Yeah. So you give the decision finally to the patient. You say, that's something empirical. If you want to do it, we can do it, but it is no medical indicated, or there is no medical evidence on it.
Okay, we just have a minute to go. I just want to cover one question, which we've had comments on before, and this is about IVF being more often included in employee benefits, in health insurance programs. Is that something that you are all aware of? Helen, do you have any insight into that? You're muted, Helen.
Sorry, I knew that was going to happen. Yes,
it
actually, it's something it always was. It's something that we are actively offering is employee benefits in preventative testing. So what we've found incredible is that while companies are seen to now be moving towards movements of giving fertility leave, menopause leave, policies around these issues regarding fertility, they'll also sometimes offer fertility treatment. So companies like Goldman Sachs will offer up to £27,000 worth of fertility treatment per employee. And what we are trying to kind of move into this space is to say that not everyone should require fertility treatment. And actually, if you were to work, rather than saying it's okay, you can just get treatment, wouldn't it be better that everyone was monitored monitoring what their reproductive health was, so that they're not kind of leaving it to chance, so that they would preventatively say we engage with every employee's health,
yep,
rather than anticipating ill health. So it's something I've become very aware of in the last while, is kind of this a bandage approach to fertility, by saying it's okay, we've got an insurance policy that will pay an awful lot of money, and what would be much better is to offer something that gave people insights into their fertility.
And very briefly, from the other three panelists, what kind of proportion of your patients currently are not self-funding, i.e. they're being funded by an employer or an insurance company, and is that changing? Cesar?
I would say probably less than 5%.
Less than 5%, okay.
But yes, it is changing. We are seeing more and more of them.
And Alison, similar for you?
Yeah, I'd say same thing.
And Salome, last word, self-funding or employer funded?
Self-funding.
All self-funding, so it hasn't
Yeah.
really taken off in your part of the world. Okay, we're going to close the session, that panel session now. Many thanks to our four panelists for their contribution this morning. It's been excellent. Stick around for the next session. We're taking a refreshment break. We will be back at 11:05 Greenwich Mean Time. So please rejoin us at that point, and we'll see you shortly. Thank you, panelists.
Thanks, everyone.
Thanks so
Thank you.
much.